Good afternoon. Welcome to this caregiver webinar presented by the Brain Injury Association of America. Today's topic is Growing Strong, Helping Your Young Child Recover After Brain Injury. Today's attendees are all muted. If you have a question, please type it in using the Zoom Q&A box at the bottom of your screen, and our presenter will answer questions at the end. Dr. Jennifer Lundine is an associate professor in the Department of Speech and Hearing Science at The Ohio State University and a clinical research scientist at Nationwide Children's Hospital. She has over a decade of experience working as a speech-language pathologist on a pediatric rehabilitation unit. Welcome, Jennifer.
Thank you. I'm so happy to be with you all. I'm coming to you from Columbus, Ohio, and we are very gratefully having a sunny day, and I hope you are enjoying a sunny day wherever you are. I'm very happy to be here today to talk to you about recovery after brain injury in young children. This is a topic that is not very often talked about and certainly under-researched, and I'm very happy to be talking to you about it today. I'm first going to share with you that I have received support for my research from the Ohio State Department of Public Safety, the OSU Center for Chronic Brain Injury Recovery and Discovery. I'm sorry that I have that name incorrect there. The Columbus Foundation, the National Institutes for Health, and the Centers for Disease Control and Prevention, though the work that the information I'm talking to you about today is not relevant or not related to any of that specific research. I don't have any other financial or non-financial disclosures to report, but I do like to report that. And also, just to give you a little bit of information about who I am, as mentioned, come from a speech pathology background. I worked on a rehabilitation unit at Nationwide Children's Hospital here in Columbus for a long time, where I treated and assessed young people with acquired brain injuries. And that's what led me back to my work as my research, or that's what led me into the research world. And now my research and teaching are focused on improving outcomes for young people, children and adolescents with an acquired brain injury. So this is the lens that I come to you with as we talk today about growing strong, how you can help your young child recover after a brain injury. These are the different topics that we'll go through today in hopes that you can leave with some working options for addressing both identification and different ideas for actually dealing with or therapy ideas for helping a young person with brain injury that you might have in your own life. So first, let's talk about some foundational ideas as we get into this talk today. I want to make sure we're all on the same page. And for the purposes of this talk today, I want to make sure, again, we're all in the same place. So when I talk about young children with acquired brain injury, I'm referring to kids under the age of 5. So these are kids who have not yet entered formal school, so they're not yet in kindergarten, and they have some kind of injury to their brain. So when I talk about an ABI or an acquired brain injury, this is some kind of injury to the brain that was not something that happened while a child was in the womb or prenatally or perinatal, so not immediately after birth or during birth. And when I say injury, it also means that this is not genetic or neurodevelopmental in origin. So this is an injury that happens to the brain after some period of typical development. And then the other important foundational term to make sure we're all on the same page is the term acquired brain injury. And when we talk about acquired brain injury, we're talking about an umbrella term that has underneath it the term traumatic brain injury, which is what we often think about when we think about brain injury. So this is a bump, a blow, a jolt to the head, which is like when someone hits their head, when they fall off their bike, when someone is struck by something or dropped. When we think about an infant that is abused or has shaken baby, or is in a car accident, for example. But then we also have non-traumatic brain injuries that fall under this category as well. And these are things like an anoxic injury. So when a young child experiences a period where their brain is deprived of oxygen. So, for example, a near drowning episode, or a cardiac arrest, or a stroke, or a brain tumor, or an infectious diagnosis to their brain. So we talk about both traumatic brain injury and also non-traumatic injuries. In a few minutes, we'll talk about some statistics where we actually know most about traumatic brain injury just because what tends to be counted in our hospitals. But most of the talk today is focused on acquired brain injury in this larger umbrella, including both traumatic and non-traumatic brain injuries together. So I want to talk a little bit about young children because it's very important to understand why this is important to talk about. And you are here today, or you are maybe listening to this recording because this is a topic that is important to you. But as I mentioned in the very beginning, unfortunately, this is not a topic that is very well talked about or very frequently talked about. And it's also, as I mentioned, very under-researched. But this is very unfortunate because 0 to 4-year-olds are the second highest risk group for traumatic brain injury in the United States of America. So first are those individuals over the age of 75, so older individuals who are at risk of falls. But the second highest risk group in the United States are 0 to 4-year-olds. Yet there is very little research on this group, specifically on their outcomes or on how we can assess and treat them, which again is really a problem in our field of thinking about development and assessment and treatment, and certainly in your lives if you have a young child who may have experienced an acquired brain injury. And what we know, I'm going to throw a very old date out there for you, and I don't want you to think that this is because I haven't done my homework. But this date here of 2013 is because unfortunately we don't have a lot of very good data past 2020, unfortunately. So this 2013 date is one of the best older data sets that we have that actually counts the number of young people and splits them up by age. So that's why I'm giving you this old data here, way back to 2013. So here are some numbers of how many young children between 0 and 4 report to an emergency department or reported in 2013 and were hospitalized. And then also another kind of larger number of young people who visited an urgent care or their family physician with a traumatic brain injury. So again, here, this bullet on the bottom is just specific to traumatic brain injury. And again, unfortunately, the statistics are old because we stopped collecting, this specific data due to some silly requirements that we don't need to go into, but unfortunately, we don't have very updated data for these numbers. But what is important to understand is that as a result, and even knowing those numbers, what we do know is that many traumatic brain injuries and certainly other acquired brain injuries go unreported. And therefore, understanding the true nature of this problem solely based on these numbers, we're really underestimating the actual problem by as much as 8 to 9-fold. So thinking about missing 80 to 90% of this problem is really staggering. And so why are these young people, why are their families not seeking medical care? This is a complex problem. So sometimes it's because families don't think this is that much of a problem. Their kid, quote unquote, bumps their head. They don't think it's that big of a deal. And so we'll talk about that a little bit as to how it's difficult with this young age group. that sometimes we're not sure when they should go to the doctor because it's hard to identify symptoms. Sometimes the issues are related to not having insurance or good medical support in general, and other issues as well. So, key patterns that we know about in early childhood brain injury or traumatic brain injury specifically. Again, we know that kids between the ages of 0 and 4, they have the highest rate of emergency department visits compared to other age groups. Boys are at higher risk than girls, especially after age 3. And the leading causes for traumatic brain injury in this early childhood age group specifically, and again, this is traumatic brain injury specifically, are falls. And it's important to know that in young kids, less than 1 is actually the actions of others. So that is meaning that they're dropped. If you have ever had an infant, I was just saying that I accidentally dropped an infant, one of my own infants. This happens. So falls meaning under the age of 1 year old, it's the action of another person, and over the age of 1, it's because of increased mobility. The second is motor vehicle crashes, and the third is abusive head trauma, which is more common for those over the age of 2. So why do we see such high rates of brain injury in this age group? We think there are several reasons, and some of those are possibly because their neck muscles and their ligaments are so immature. We know that, especially infants, they have those floppy heads, and so that may make them more vulnerable to having an injury to their brain because their neck is not strong enough to protect it. They also have larger heads relative to their body. So again, makes them more prone to falling. Again, they have a higher center of gravity because their weight is centered so much in their head. And also because of the way their brain is literally built. They have immature axons. In these early years, they're not completely myelinated, and so their axons are more prone to be damaged. And this also increases the susceptibility to have damage that is spread throughout their brain. So when their brain is damaged, it tends to be more spread throughout the brain instead of localized to a specific area because of the immaturity of their brain development. So what makes pediatric brain injury unique and different from a brain injury in an adult? This is something that as I worked clinically, I became very interested in, and this is what really drove me into the research world, is why is working with young people different? Why can't we use the research from the adult world to help young people with brain injuries? And one of the key reasons is because in a young person that experiences a brain injury and development are occurring at the same time. And so not only does a child have to recover from their injury to their brain, but they also have to continue developing. When we, as an adult, might experience a brain injury, our brain is already developed. Now, yes, we're still learning and we can still grow and change, but we have learned the basic skills that we need to take care of ourselves. We have, learned language. We've learned how to complete our activities of daily living. Our language, our fine motor, our gross motor skills are essentially fully developed. Young people, especially thinking about kids from 0 to 5, think about all the development that is occurring in those first 5 years. Kids are learning how to walk, how to talk, how to feed themselves, how to use, how to dress themselves. All of that development is occurring. And when they experience a brain injury, that development is now stopped and they must recover from the injury. And then their development has to continue while it is now working on a brain that isn't quite functioning as well as it was before. So it's that injury and development working at the same time in the same brain that makes a pediatric brain injury so particularly unique and challenging. Additionally, what we've learned is that the skills that are most vulnerable to an injury are those that are not yet fully developed at the time of injury, and those that are in the process of developing. So again, thinking about a child that is at the age of 3 when they experience a brain injury, who maybe hasn't learned how to, use complete sentences or hasn't learned how to read. So those skills have not yet developed, but they have to learn those things. They have to learn how to sit down and pay attention in a structured kindergarten classroom. They haven't learned those things. Those skills are the most vulnerable because they haven't learned them yet at the time of their injury. Often they're able to get the skills back that they had prior to their injury. It's the skills in the future that are most vulnerable. And so as a result, what we see is that the consequences of their injury evolve over time. As I just mentioned, they often are able to get back to the point that they were right before their injury. So their recovery typically looks very good. They recover and they get back to, back to baseline, back to where they were right before their injury. It's those future skills that are most at risk. So this developmental vulnerability is the biggest challenge that we have in young people with a brain injury. And so therefore, the younger that they are at the time of injury, the greater risk that there is the potential for challenges in the future. Because of all of that rapid maturation that's happening in the brain in young children, there is the potential for higher vulnerability of later challenges. Unfortunately, injuries that happen to a young child are predictive of poor outcomes. Now, certainly these are typically more severe injuries, but the more we learn, the more we begin to understand that even less severe injuries can have persistent problems into the future for young children. And we also think about those sensitive periods of development for cognition and language and social development. And so if a child sustains an injury during those critical periods, that we can see that children will grow into their deficits or appear to develop deficits later because those skills are not developing at the rate that we would expect for a typical child who has not sustained an injury, if that makes sense. Okay, so now let's talk about how do we identify some of the symptoms that we might see if a young child sustains a brain injury. So it is challenging to identify a brain injury in young children. And why is that? Well, unfortunately, young kids, younger than the age of 5, are not as verbal. They don't have the language to tell us, ouch, my head hurts, I have a migraine, my vision is blurry. I am, that sound or light is really bothering me today, and it didn't bother me yesterday. They don't have the language to quite tell us the things that an older child or an adult might be able to tell us or to describe their symptoms. So that makes it very difficult. Also, children are already developing at different rates. We know that development already has a wide range. If you have multiple children, you might already know that one child develops at a different rate than another child, or you have kids that you've seen, neighbors or kids in your family that have developed at different rates, and they may not be delayed, they just develop at different rates. And so it's hard to know, is this a delay? Is this a delay due to a brain injury, or is this just typical development for that child? And also, a lot of symptoms are subjective. So is this child just being fussy today, or is this brain injury related? So again, sometimes it is difficult to parse out these challenging symptoms because they're not clearly objective and diagnosable. And age matters. So what we expect for a 2-year-old versus a 4-year-old or a 5-year-old are different. And again, putting it onto the other idea that it's going to be different for every child makes it even more challenging. So what are some red flags that we can look for when we are thinking about a child who might be in our life that we are concerned about, who maybe had an incident, or our own child, and we're trying to figure out, is this a behavior that is concerning to us, or should it be concerning? So we're going to talk about 4 different domains and what we might look for. And I want to make sure to point out this is very much drawn from the work of Miriam Beauchamp, who is in Canada and has done some really amazing work taking some of the adult symptoms of brain injury and specifically concussion, and worked with families of young children and tried to put these into terms that young families and young children can understand and describe, so that we can relate these to young children's symptoms and the way they're appearing to families. So first, let's talk about cognition or thinking and how these symptoms might appear for young children. So again, what we should be thinking about is if a child hits their head or has some kind of an incident, and again, this could be traumatic or non-traumatic. So we could think about an infectious process like meningitis or encephalitis. Maybe they had an incident and at first no one was concerned about it and they were sent home. But then you start to see some symptoms and you begin to become a little bit more concerned. Or, I mean, goodness, this would be very serious, but they had a near drowning episode and they were deprived of oxygen for a short time. And no one is concerned about a brain injury at first. But then your child is home, or you have a child in your preschool and you begin to see some of these symptoms. So again, it doesn't have to be a traumatic brain injury. There can also be non-traumatic brain injuries here. So you might notice that this child is, again, acting differently than they were before. They're more easily distracted. They might need more repetition than they did before. You're asking them, they used to follow directions very easily, and now you need to repeat those directions multiple times in order for them to follow them. They seem clumsier than normal. So it's like they're just not able to, their gross motor skills seem off. They're not able to balance, or they're tripping over their own feet, and just not able to manage their own body in space. Or there are changes in their speech patterns. So again, if this was a child who was verbal before, and suddenly you've noticed just small changes in their speech, whether it's their articulation, or they were speaking in full sentences and now they're struggling. You've noticed that they're having trouble with word finding. They knew names of things before and they're struggling to come up with those words. So again, it could be very subtle. But you're noticing these changes. Again, these may be signs of cognitive changes related to an injury to the brain. Physical changes that may also be indicative of a brain injury could be things like appetite changes. So again, if we think about how an adult might feel after a concussion or a brain injury, you could have a stomach ache, you feel nauseous. So what does that look like in a young child? Their appetite changes, they have complaints of a stomach ache, or they're whiny, they're holding their tummy, they don't want to eat. They're holding their head. So they may not be able to tell you they have a headache, but they're holding their head, they're crying, they're whiny, they look pale, they're rubbing their eyes. So again, how might a child indicate to you that their head is hurting, that their tummy is hurting? They may also react to loud noises. So again, if we're thinking about what might it look like if a child is overly sensitive to light or sound. To light, they may be rubbing their eyes. They may not want to go outside, or to sound. Similarly, they may not want to go outside because it's too overwhelming, or they're reacting to loud noises. They're covering their ears because the sound is too much for them. Or they're taking longer or more frequent naps, or they're sleeping much longer than normal. For some parents, we might be thinking, oh my gosh, this is so great. Look, my kid is suddenly sleeping. And they used to be a terrible sleeper. So certainly, that might feel like a win, but it also might be a red flag. So again, thinking about what was your child like? Was there an event that occurred that might actually raise a red flag to say, I don't actually think this is a good thing. We might connect this to an event that happened that might be indicating something bad. What about mood and behavior? Similarly, we might see more fussiness, more irritability. They're crying more, they're throwing tantrums. And again, these are things that are outside of the norm. Yes, 2-year-olds, 3-year-olds, they cry, they throw tantrums, they are irritable. This is totally normal. So we're looking for things that are abnormal for this child. It is not typical for them to throw a tantrum every day, all the time. It's not typical for them, to throw a tantrum when you leave or things like that. So again, looking for patterns that are abnormal for your child or not calming down as usual, or they're not wanting to participate in preferred activities. Again, another potential red flag. We also might see comfort seeking or more interdependence or dependence on caregivers. So you might see excessive clinginess. They want to stay close to their parents or their caretakers. They want to be held all the time. They might also regress in toilet training. So this is something that Dr. Beauchamp found in the families that she worked with, that kids actually regressed in some of their developmental norms. And toilet training was one of them. Kids would have accidents. And also they didn't want to be alone. So again, signs that are abnormal for your child or for the child that you may be working with. Again, atypical and something that you could actually pinpoint or relate to an event that happened to that was related to a hit to their head, a bump to their head, or some kind of event that potentially is indicative of a potential brain injury. So I just want to talk through two quick case studies just to kind of think about how this might look. So let's think about first a 12-year-old boy. So this 12-year-old boy falls off a swing at school and hits his head on the ground. And he doesn't have a loss of consciousness. That's what LOC is. So no loss of consciousness. He's slightly confused at first. He cries, but he calms down after a few minutes. His parent was called and picks him up from school. He doesn't go to the doctor. The parents just take him home and they decide to just lay low for the evening. The next day, he complains that he's tired. He has a headache. He cries during lunch, which is not normal. He says that he can't handle all the noise. He goes to the nurse at school and he asks to go home after lunch that day, which is not normal for him. After he gets home, he sleeps for 3 hours, which again is not normal. And he takes 2 hours to complete some simple homework, which is not normal for him. The next day, he oversleeps. He fails a vocabulary test at school. He gets in a fight, a verbal argument with one of his friends in the classroom. And so after that, the teachers call his parents and say, something's going on. These are not typical behaviors. And so the parent decides, okay, these all kind of link up with this hit to his head yesterday. We should go see his pediatrician or follow up with a concussion clinic, right? So these behaviors are clear enough that we could say this kiddo probably had a concussion because we're clearly seeing check, 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 all these different behaviors that indicate he probably had a concussion and needs to be seen by a doctor. But now let's look at a 3-year-old. So let's think about a 3-year-old who's at daycare or preschool, and he falls off a swing at preschool and he hits his head on the ground. And he also doesn't have a loss of consciousness, cries, but he calms after a few minutes. They call his parents, parent picks him up, they don't go to the doctor, they just decide to lay low at home. That night, the 3-year-old is fussy. He's kind of irritable. But they sit down and watch a show together, and he easily goes to bed after a bath and he sleeps all night. The next day, this kiddo is fussy and he's irritable at school. He's picky at lunch. He has difficulty sharing toys. He cries instead of using his words. He naps easily and he naps longer than usual. He's clingy with his teachers and he has one accident. That night, he's fussy and irritable at home, but he relaxes when his mom sits down to watch a show with them and he goes to bed easily after a bath and he sleeps all night. So without knowing that this kiddo hit his head, how would we identify these behaviors as atypical or not? So again, the previous case with the 12-year-old, it feels pretty clear, I think, that check, check, check. This kid sounds like he had a concussion. But this little 3-year-old, I don't know, he's picky at lunch, he's irritable, he cries instead of using his words, he takes a nap longer than usual, he calms down when he gets to watch a show. Like I mean, my kids still do that. I mean, my kids are teenagers, so that's maybe not the same, but that would have worked for my kids. So, I don't know, these feel like very normal behaviors. So do we think that this child had a concussion, or is he just being a normal 3-year-old? But this is an example of how it can be tricky in a young child to figure out, is this something that we need to get checked out, or is this just typical 3-year-old behavior? So again, thinking about young children and hits to the head or brain injuries, again, the complaints and the symptoms that we might see are less focal. So they're more widespread. We see general fussiness. We might see regression in developmental norms. There are more global developmental changes. And again, they're not huge. So when I say, general developmental changes, I don't want you to think that we're seeing, a 3-year-old that suddenly looks like they're a 1-year-old. That's not what I'm saying. We may see very subtle changes. Like the 3-year-old who just suddenly is kind of whiny and he doesn't want to use his words today. He prefers to be fussy instead and point and, or isn't using full sentences. He's just saying, mine. So again, not something that is totally alarming, just looks like he's having a bad day. And again, we're reliant on adult observations because young children aren't able to self-report, because they don't necessarily have the words or the description to tell us about how they're feeling and to describe those internal feelings like an older child would. But as we learn more, we need to think about when things don't look right, we need to ask questions. So by thinking about these different symptoms, how kids are appearing consistently different, and then asking questions about, hey, did something happen? And not saying, did your child have a traumatic brain injury, but asking, did your child hit their head? Did something happen that might have led to these changes in their behavior? Anything where they fell, were they sick, something like that. Because most people aren't going to understand the words traumatic brain injury, but asking questions to try to understand what could have happened that led to these changes in behavior is going to be where we can start to get to the root of the problem. Okay, so then how might we start to assess this? And when we talk about this, I am sensitive to the fact that likely a lot of people watching this webinar are probably not professionals. And so I want to talk about this sort of globally, and certainly you're welcome to reach out to me. But what I'm talking about today is more consideration of how we might look for these things across the spectrum. So regardless of who you are to a child, you might be a professional, you might be a parent or a caregiver. but thinking about how we might spot these things regardless of where you might be in a young child's life. So thinking about where might we spot these spot kids, and there are lots of different places that we might be able to spot young children, or where your child might be spotted if these symptoms arise. So it could be in a preschool screening, it could be in a special needs preschool, an outpatient clinic visit, a kindergarten screening, a pediatrician well visit, an urgent care visit, and certainly family members, babysitters, close friends, anything like that, where someone who knows your child well, could say, hey, I feel like this is a change in their behavior. Did something happen? Or where you could say that about a child that's close to you. So let's talk about, what does this mean? And what is a developmentally sensitive assessment? First of all, it's important to understand that assessment is ongoing. So for young people specifically, we are watching them over time. When a child, so let's assume these are assessments for kids who we know experience an injury. So let's start there. And when we know we have a child who has experienced an injury, and now we're going to be monitoring them and watching them over time, we need to be observant over time. So we're going to watch for that recovery to get back to baseline, but then we're going to need to make sure that we're monitoring them over time. So we've talked about how those they are vulnerable um, to potential changes or developmental, why am I struggling with this? They are vulnerable to having delayed development of later skills, even months or years after their injury. I'm sorry that took me a minute to come out. So it's important that we're following and continuing ongoing assessment. So as they are continuing to develop, we're going to be watching to make sure, are they staying on track? Are they keeping up with their peers, or is their development continuing in its regular path? Or are we seeing, oops, this is something that is not happening as we would expect. And so then we want to make sure that we're following up with a professional to get that extra help. We also want to make sure that we're thinking about how that injury is integrating with development. Here is a much easier way to say what I was just stumbling over, that young children may grow into their deficits. So again, that those difficulties may appear after that recovery actually happens. So they may get back to their baseline, but then we may see that they grow into their deficits, meaning that new difficulties may appear as later developing skills aren't developing as we would expect. So as we expect things, we expect them to get better at harder skills, they're not keeping pace with that normal developmental trajectory. And that's where we really need to be on top of watching and then referring or asking for a professional referral when those concerns arise. So again, we're saying this in lots of different ways. We want to be looking at now, but we also want to be thinking about the future and how this may impact their future skills. So if my child is having trouble with memory right now, I want to think about how that's going to impact their ability to learn how to read in the future. So I want to be thinking about that even as we're working right now. And I also want to be working with lots of people. Brain injury is something that requires an interdisciplinary approach. We need people from all different professions helping, with OT, PT, speech, reading, teachers, potentially social workers, counselors, all those people who can support your family to make sure that we're getting the best support for your family and your child as possible. And we'll talk about transitioning to kindergarten in a few minutes, but that's going to be a key piece as well. So making sure that if you are a family that is listening to this, that you have the support that you need to answer the questions that you have. And if you're not even sure what your questions are, that you also get that support so that you can understand what are the questions that you should be asking. Another important piece is understanding what is important to your child and what should they be able to do. If you're not sure what development should look like for them, again, find the people who can help you ask and answer those questions. We want to be thinking about home. We want to be thinking about school. We want to be thinking about community. If you want your child to be playing rec, soccer, or baseball, that's what you should be working on. How do we get your child out there? Or learning martial arts or ballet or gymnastics, whatever those things are. How do we get your child into the community? How do we get them back into preschool? All those things are really important. And so we want to be seeing how is your child working and functioning in those different environments, and how can they be supported to be successful in those environments as well. And we also need to include the perspectives of multiple people. So if you have a child who is in those different environments, so is at preschool, is in a ballet class, for example, and they had an injury and now they're struggling with their attention and maybe some behavioral outbursts, you want to ask questions of the ballet teacher and of the preschool teacher. What is happening? What is making those behaviors worse? Are there strategies that are helping? Can you get someone to help you alleviate those challenges in the classroom? And who is helping you? Who is supporting you through those different environments, so that you can set goals across those different environments and everyone can be working together. We also want to use multiple methods. So working with brain injury is never simple. But we want to observe, we want to engage in play activities, we want to ask questions, we want to ask for referrals to professionals. And sometimes that might involve standardized assessments, but not always. Especially with young kids, that might mean play-based assessments, or talking to you as parents to find out what is happening at home, talking to your child's preschool teachers to find out what is happening at preschool. So observing and doing interviews with other people. So we want to involve the people in your child's life to figure out what is happening in those different environments. And it's essential that we're prioritizing real world function. We're not just focused on step-by-step tasks. Yes, learning how to tie a shoe is important. That is functional. But we want your child to be able to play successfully with his or her friends. We want him or her to be able to sit at the family dinner table and not have outbursts. These are all very functional tasks that are essential to your family. Whatever your family goals are, those are essential for the therapist or whoever you might be working with to understand, and what you can make a focus of your assessments as well. So what is it that you want to be successful, you want your child to work on, and how can we focus on that, or how can you focus on that? But it doesn't have to just be a structured task. We want to think about the whole functioning of your family, and how that child can work within it to be successful as well. And as I've mentioned several times, because this is super important, is we want to always be monitoring for later emerging needs. We want to make sure that we're watching for later emerging deficits. And I realize, holy cow, I'm talking too long. And then we want to tailor for the developmental level of your child. So if they're 2, if they're 4, we're going to obviously adjust the expectations based on your child's level of development. Okay, I'm going to have to kind of go quickly through the intervention. The basic foundations of intervention for young children with brain injury. Development matters. Ongoing assessment and observation should guide our treatment. We're going to focus on environmental support, not just child level interventions. Therapy is play. Play is therapy. We're going to prioritize foundational cognitive communication processes. So this is thinking and communication. Intervention is long-term, and we're going to plan for kindergarten early and often. So I'm just going to take us quickly through these slides. And I apologize that we're going to move quickly. I know the slides are available to you. Um, uh, when we think about intervention, we are going to think about how and where your child is in their developmental trajectory. We want to obviously get them back to where they were before their injury occurred, but then we're going to think about how development needs to continue to proceed, and where they might get stuck, but then also what needs to happen next. So that is a very important perspective for treatment or intervention. Ongoing assessment is going to guide treatment. So again, we're going to be continually monitoring what is developing and where is a hiccup for this child, and how then can we adjust. Where do we see, when we see a hiccup or when we see them get stuck, how can we adjust so that how do we adjust our expectations? It doesn't mean that we have to stop that child or stop our treatment. We might just need to adjust our expectations and then teach them in a different way or support them in a different way so that they can be successful. And then work on developing that skill in a longer term way. We're going to focus on environmental supports, not just focus on trying to make the child better at something. A lot of times when we're working with brain injury, and if any of you have dealt with adults with brain injury or older children with brain injury, we know that a lot of times the best treatments that we have are supports in the environment. And so this is the same strategy for young kids. How do we create an environment that is supportive? So how do we change routines? How do we develop schedules so kids know exactly what's coming, and keep things in a routine way? How do we change our communication by making things simple and structured? How do we change our expectations? We don't expect that they're going to follow 5-step commands, that they're going to hear us from another room and follow our instructions. We might need to be in front of their face giving them an instruction. It's not going to be the same as our other child who excelled at all of these things and didn't have a brain injury. This is going to be a different child, and we need to adjust our expectations accordingly. We might need to scaffold and support their attention in a different way. We need to turn off the television when we're giving them instructions. We can't expect them to follow those directions if there are 10 things happening in the environment. How do we support their memory? We have a schedule. We have things, in a picture schedule or something written down. We have alarms set, those kind of things. How can you support your child in the environment to be successful? If they're successful, they feel better, they feel positive, and then they are inclined to continue doing the thing. Play is therapy. We shouldn't be, drill is important in changing our brain. Yes. However, play is how we do that with kids. So that is important. Remembering that thinking about goals, we can do that in functional activities, but doing that with play is what is functional for kids. So how do we support therapy goals in play-based activities, in functional activities for kids? This is the most important thing. In any therapy, whether we're working with young kids, whether we're working with 45-year-old adults, the most important thing is that they are motivated to do the thing that we're asking them to do. They're only going to want to do it if it is motivating to them. And so picking something that is fun and motivating is going to make them want to engage. And with kids, same thing. You want them to be engaged. You want them to be motivated to do it. The more they do it, the better they're going to get at it. And play is typically the way that works. And so that's what we want to choose all the time. We know brain injury affects attention. It affects processing speed, working memory, initiation, flexibility. It is the same with young children, except those processes are typically not very well developed in our young children. We know that too. Young children do not have inhibition, right? These are kids that are doing what they want when they want it. So we already expect that they're going to struggle with these skills, but we need to help strengthen them and support their development now that they have a brain injury. So we need to focus on those foundations as they are continuing to develop. We also can try to and do the best we can to create a predictable structure and use explicit teaching. So we shouldn't think that by, just living our life in a nice structured way is going to rub off on our child. We need to be explicit. We need to have structure and do that explicitly. And one of the best ways we can do that is model our thinking out loud. We can talk through things that we're doing. An example here on the slide is, okay, first I'm going to get my PJs out of my room. Then I'm going to take them to the bathroom. And now I will be ready for my bath. Now you do that. Now you've just modeled that for your child. Breaking tasks into small steps. First, we do this. Second, we do this. We don't do four things. We don't try to do four things at one time. So being structured and using explicit teaching to model that behavior for your child. Intervention is long-term. This is a marathon, especially with your young child. We have a long time. They have so much development still to go, and you're still building the foundation for them. That foundation is being built at home. It's being built in preschool, and families need to be prepared that this is a long-term process. And also schools need to be prepared as well. And so a very essential point is that we need to be planning early for the kindergarten transition. It is essential that schools are notified that a child had a brain injury. And I want to express this point so clearly. A lot of families feel very hesitant to share with the school because they don't want their child to be labeled. And I would like to give my biggest, strongest push to encourage families to share with the school, because I want to encourage families to advocate for their children to be observed very closely, especially as they enter kindergarten, because I can tell you so many stories of young people that I treated at the hospital who went into kindergarten. Their schools were not notified, and those children really struggled because the schools were not prepared. And the families weren't prepared. That child was doing really well in their preschool and in their home. And when they went into the structured environment of school, they really struggled. So all of those difficulties that they grew into in that structured environment popped when they were in kindergarten. And if a school is prepared, then hopefully those issues can be caught if they appear. And hopefully they don't. But if they do, a school can be prepared. And certainly there are resources out there if families need support as that transition happens. But it is so essential that schools are made aware of that injury. And not all schools are asking about injuries when children are doing kindergarten screenings, though. It is so, so important. Okay, where do we go from here? These are points that we've already talked about, so I won't repeat them, so we have a few minutes for questions. I'm so grateful for your time, and I wish we had more time, but thank you so much for your time today. Brianna, do you deal with parents who are conditioned to the mindset building strength and be strong instead of acknowledging potential injuries? Yes, for sure. Yes, I guess is the short answer. And I would just encourage families that, brain injuries are a real thing. And we talk about, the evidence that we now have that they're really changing. We have plenty of evidence now to show that in children, changing their future outcomes. And so with supports, we can improve outcomes. And by ignoring them, we're leaving children open to potential challenges. As I mentioned, many parents do not report the injury when the child is entering kindergarten. Thanks, Julie. Do I have any suggestions on how to educate parents about the importance of this reporting. My suggestions are sharing with parents that, again, what I just shared is just the importance is schools need to understand, because it's the only way that they will have the possibility to observe this student as having the potential for a learning difference. And so therefore, they might view attention difficulties with a different light, instead of viewing it as an attention problem or a behavioral difficulty. They might view it as, okay, this child has had a brain injury, and therefore I might connect with a different tier of support. I might ask for the speech language pathologist or the school counselor to come in and give strategies. As a parent, you can then say, oh, I see my child is having difficulties. I'm seeing notes from the teacher. I want to remind you, I told you my child had a brain injury. I would like to ask for an evaluation. Those kind of things can happen more quickly if the school is aware of a child's injury, because otherwise the challenge is it's very easy for a child to quickly go down that negative slope. I had a former patient who basically was told they failed kindergarten because they didn't learn anything. And simply because, not simply, but because they struggled with learning because they couldn't sit in a structured classroom. They struggled with changes to the schedule, all things that are very typically brain injury related, but the school wasn't aware. And so they were essentially blamed on other things. And the child essentially lost a year of school because they weren't being dealt with appropriately. Okay, so Lori is asking about epilepsy and multiple seizure disorder. There is a continued brain injury until the seizures are brought under control. How do you connect with the school for the education when it's unclear as to what areas are injured to affect performance? Outside the home, how can educators assess or contribute to the observation, diagnosis, and needs? Certainly with a complex diagnosis like epilepsy or multiple seizure disorder, it would be ideal if the school was connected to someone at the hospital or the medical clinic like neurology, so that the school counselor or the school psychologist had some understanding of that child's seizure disorder specifically, what kind of seizure medication or seizure control. I'm sure that the school nurse, if this is a child that has epilepsy or multiple seizure disorder, I'm guessing there's probably some kind of seizure prophylaxis or care that the school is aware of, and so likely some kind of medication that the school is aware of. I would really like that. I would like or recommend that the school also be connected, the school psychologist or counselor or SLP also be connected so that they can understand what the specific cognitive needs of this child are, and that those are being accounted for in the child's classroom, because that is obviously very crucial. And I am a very strong proponent of curriculum-based assessment, because we don't have great assessments for youth or students with brain injury for school-age youth. And so I am a very strong proponent of actually looking at what these kids are doing in the classroom, and how they're doing managing the curriculum itself. And outside the home, how can educators assess or contribute? So that's my biggest takeaway or biggest point of encouragement is asking educators, including people like the speech language pathologist or school psychologist or school counselor, to be doing curriculum-based assessment, so that they can weigh in to exactly what is this child doing in the classroom, and then sharing that so that those goals can be addressed at school. What does this child need help with specifically in the classroom so that they can access the curriculum? And those are things like memory, attention, higher level language, and then working with the family so that those goals are carried over at home with, how do we handle homework? How do we help with outlining material, those kind of things. Sorry, Lori, that's an area that I feel very strongly about. Have there been any long-term studies on the impacts of repeated TBI in young children as adults? Repeated TBI, I'm gonna presume that you probably mean abusive head trauma, though I'm not 100% certain, Ellen, that that's what you mean. There are some studies looking at abusive head trauma. It is a unique because it comes with a lot of other social issues also. And so it is a different population because it has sort of different associated issues with it. There are some studies, but not a lot. And there are not good long-term studies. There are a few studies from Australia and New Zealand that have looked at long-term outcomes of young children, but there are very few. And those don't specifically look at repeated TBI outcomes in children as adults. What is the best way to support concussion or TBI recovery in a holistic way? If we're talking about young children, I'm going to say that the best way to support concussion or TBI recovery is just thinking about functional recovery and how to assess and intervene in a functional context. So thinking about development. So again, I'm going to talk specifically about young children, since that's what we're talking about today, thinking about where this child is in their path of development, and then what would we expect them to be doing developmentally, observing what they're doing, getting them connected to any professionals, and that would include educators that could support the family and that child in that path, and then continuing to watch that development as they move forward. So as long as we are aware and monitoring, and then helping to support that development in a functional, everyday, I'll use the word you used, holistic way, that's the best thing that we can do. But making sure that we're continuing to watch those kids, that is a very key piece, because brain injury does not go away. It is a chronic condition. These children's brains, once they're injured, they're always injured. It doesn't mean that they will always have, a negative impact in their life, but there is that potential. We don't know who recovers well and why certain people recover well, but there's always that potential. And so we need to be monitoring if we want to be able to catch the kids who are going to need support into the future, so that we can give them the best chance.
Yeah, well, great. Thanks so much, Jennifer. And thanks for answering the questions too. We really appreciate that.
Absolutely. Thank you all.